Welcome to the second part of our lecture series on meningitis. And during this second part, we will discuss chronic meningitis that involve mainly fungal meningitis and TB meningitis. I am Dr. Teke Apalata, a specialist in clinical microbiology. So let's look at this first part of our lecture series on meningitis and mainly chronic meningitis. So fungal meningitis, we will mainly focus on cryptococcal meningitis, that is a type of fungal meningitis. The other commonest cause of fungal meningitis is candida meningitis, but we will not discuss that in this lecture. So we will mainly discuss cryptococcal meningitis. And we will also discuss tuberculosis meningitis, that is another commonest cause of chronic meningitis in our setting. So let's illustrate this with this clinical case. It's about a 55-year-old woman, this patient has been getting worse, has been getting more confused over the last 2 months. And since the past 3 days, she has been vomiting and suffering from lack of energy. She has no neck stiffness, but found to be HIV positive with a CD4 count of 100 cells of 100 cells. Okay, so we have some clue here regarding this case. Okay, so we have this patient who has been getting more confused over the last 2 months. So it gives you an indication of a chronic condition. So this has been happening for the past 2 months now. So it's not an acute case, it's not an acute meningitis. So this is a case that is chronic. Okay, then for the past 3 days, the patient then starting having vomiting and lack of energy, So the other key information here is that this patient is immunocompromised. She is HIV positive with a CD4 count of 100, with a CD4 count of 100. Okay, so this tells you that this is high likely to be a chronic meningitis. And another thing you can see here is that this patient does not have a classic presentation of acute meningitis like your headache and neck stiffness and so that, but she looks confused. She has vomiting, that is now, recently she started to have an increase in intracranial pressure, with a lack of energy. Then she is HIV positive. We know that cryptococcal meningitis and the TB meningitis are both, common in patients with HIV, especially HIV with a low CD4 count. So it's an option, it's a possibility that this patient might have either cryptococcal meningitis or TB meningitis. Okay, now let's look at the differential diagnosis, what separates the two clinically on a clinical presentation. So you will see that in a patient with a cryptococcal meningitis, on the left inside, a patient with cryptococcal meningitis, those patients are often immunocompromised. Okay, they are often immunocompromised with a very low CD4 count. They can have headache, confusion, nausea, and vomiting. So this patient here is immunocompromised. She's HIV positive with a CD4 count of 100. She's confused, for the past 2 months now. She's starting now having vomiting, okay? Then fever and neck stiffness are less common in this patient with cryptococcal meningitis. And we have seen that this 55-year-old female patient does not have fever. She does not have neck stiffness. So with regard to this, if you compare to TB meningitis, the patient will have headache, fever, neck stiffness, photophobia, delirium, and the cranial nerve pulses. So if you try to judge, you go into the hypothesis that this is a case of chronic meningitis. That can be either cryptococcal meningitis or TB meningitis in this HIV positive patient. But you will see that symptoms are pointing more toward a cryptococcal meningitis rather than a TB meningitis. But you still need to do further tests, to try to approve or disapprove your hypothesis, what you are thinking of. Okay. Now, what are the investigations you are going to do? In a case when you are suspecting cryptococcal meningitis, you still need to do CSF cultures. You request for cultures. You request for a PCR, okay, and also staining, like Indian ink and so on for cryptococcal infection. Or crypto antigen, you can also do a crypto antigen test, So it is already known that the patient is HIV, so you don't need to repeat that. You can also request for blood cultures just to ensure that, the infection is not disseminated, okay? And you can request either CT or MRI just to rule out other intracranial pathology. But in a case of TB side, you still request for CSF culture, but you need to indicate that you are also suspecting TB, okay? But you need also to do a bacterial antigen test, okay? So CSF PCR, we can also do a CSF PCR. She is known to be HIV. Blood culture, you can do that. But most importantly here, you need to have a chest X-ray done, to try to look for pulmonary tuberculosis. So usually this patient might have pulmonary TB, then that disseminates also to a TB meningitis. So you need to look for those tests. So those are further investigations that you can do to try to separate your two hypotheses. So you are then going to do a spinal tap. So this is what we call a lumbar puncture, So this is where you are going to do it. It's usually between L3 and L4. Between L3 and L4, that's where you are going to place your needle. So why you have to come between L3 and L4? Because you can see up here, there is a spinal cord. You need to avoid that. So those are the vertebrae, so you are going to go between the two vertebrae, but here you have a spinal cord, okay? Then the CSF fluid is in between here. So you go here between L3 and L4, you go far away from the spinal cord to avoid any problem to paralyze this patient. So that's where you are going aseptically with your needle to go and collect the CSF. And then you have your tube where you start collecting the fluid, okay? So this patient, CSF lab result come back, okay? The appearance is cloudy. You can see here, it's not clear, it's cloudy. You can see that it's cloudy, and the white blood cells, you have 400 cells per microliter. The glucose level, it's very low, and the protein level, it's around 1 gram per liter, okay? So this is a chronic conditions, okay? Chronic meningitis. With this clinical presentation, it can already make you suspect, okay? Support your diagnosis of cryptococcal meningitis. So just to refresh your memory again of what a normal CSF looks like, you can see here the appearance is clear. If you compare to this one, you can see that it's turbid, it's cloudy, you can see that it's different from this. This one, it's very clear. This is a normal CSF, how it looks like. And the white blood cells, we say that they should be less than 5 cells per microliter and usually not neutrophils. And the red blood cells should be less than 10. The protein between 0.15 to 0.45 gram per liter. It should be less than 1% of the serum protein concentration. The glucose level should be between 2.8 to 4.2 millimole per liter. That is 60% or above of the plasma glucose concentration. And the opening pressure is between 10 to 20. Now, if you have to compare the CSF lab findings between fungal and TB, and here I added the colon on a spirochetal because sometimes people with a neurosyphilis can also present with chronic meningitis. Okay, so you will see that the appearance here in a case of fungal meningitis can be, the CSF can be clear or cloudy. Now in this patient, we found that the CSF was cloudy. Okay, but in TB meningitis, it's more opaque. It's opaque, and if left to settle, it forms a fibrin web. Okay, so that's very typical for TB CSF appearance. So the white blood cells, okay, it's elevated. They are both elevated, both sides. And in fungal meningitis, it's more predominantly lymphocyte. Okay, and it's elevated, but it's between 10 to 500 cells per microliter. In TB, it's elevated, but it's more than that. It's up to 1,000 cells per microliter and predominantly lymphocytes. The glucose level here is less than 45% of serum glucose. Here it's less than 40% of serum glucose. And the protein level elevated, and here also it's elevated, but it's usually more elevated than fungal meningitis. Okay, so you can see that there are similarities in terms of the analysis results, but the appearance usually makes also a big difference, the appearance of the CSF. So looking at this patient here, the appearance is cloudy, white blood cells, it's 400, so it's here, it's not highly elevated, so it's pointing toward cryptococcal meningitis, and the glucose level below 40, protein level 1. So the differential diagnosis here, it's mainly pointing toward a fungal or cryptococcal meningitis. So if you combine clinical presentation and CSF analysis from this patient, you can easily, your leading hypothesis should be cryptococcal meningitis, but always followed by TB meningitis and query neurosyphilis. You don't really have more evidence in terms of clinical history to suspect neurosyphilis. But your working hypothesis, number one, it's cryptococcal meningitis. Number two, it's TB meningitis. Now, you will request a microscopy testing. And when they found the presence of budding fungal bodies, that's what you see in a patient with cryptococcal meningitis. But in patient with TB, that's what they are going to find if they do what we call a Ziehl-Nielsen testing. So this is the picture of a patient with who is infected with TB meningitis, and this is fungal meningitis. Now, if it's neurosyphilis, the cause is Treponema pallidum, and it's usually too thin. It's a spirochete. It's thin to be seen under the light microscope. Okay, so we have to do other specific tests to try to identify the presence of Treponema pallidum. Now, in this specific patient, the diagnosis is more pointing of cryptococcal meningitis. So how do we manage cryptococcal meningitis, especially in HIV-infected patients? We manage them in 3 phases. The first phase is what we call the induction phase. During the induction phase, we put the patient on amphotericin B, and we combine that with flucytosine, okay, for 14 days. For 14 days, we put them in combination of amphotericin B and flucytosine, okay? Then after 14 days, we move into what we call the consolidation phase. The consolidation phase where we are now going to put the patient on fluconazole or 400 to 800 milligram daily for 8 weeks. For 8 weeks. Then after 8 weeks, we move the patient to what we call maintenance phase, where we reduce again the dose of fluconazole, okay, to start taking fluconazole 200 milligram daily, okay. So fluconazole maintenance therapy can be stopped in selected patients who are asymptomatic and have a sustained increase. They manage to increase their CD4 count of greater than 100 cells for more than 1 year. So if they manage to increase their CD4 count and it remains elevated, they are clinically stable, so asymptomatic, so you can decide to discontinue. But otherwise, they will continue with fluconazole 200 milligram daily. So those are the 3 phases when we manage cryptococcal meningitis in HIV positive patient. So what we do, we follow this flow chart. You do a cryptococcal antigen screening. Usually it's done in all HIV positive patients whose CD4 count is below 100. It's called a reflex test. So everyone who is HIV positive, CD4 count to be below 100, we do cryptococcal antigen. So if the cryptococcal antigen result is negative, we start those patients, we initiate them on antiretroviral therapy. But if it's positive, we don't start antiretroviral therapy immediately. We try to evaluate this patient to see if the patient is symptomatic. If the patient is symptomatic, usually you can start fluconazole high dose, 1,200 milligram daily, and you refer that patient to the hospital where the lumbar puncture should be done. Okay, then if the lumbar puncture confirms a diagnosis of cryptococcal meningitis, immediately you put that patient on, you start induction phase, amphotericin B plus fluconazole 800 milligram daily for 2 weeks in the hospital. During this phase, the patient will be in the hospital. But if your patient was asymptomatic, if he was asymptomatic, then you just put this patient on fluconazole 800 milligram daily for 2 weeks as an outpatient. But if you confirm that this patient is symptomatic and you also confirm that the diagnosis of cryptococcal meningitis, you start induction phase, amphotericin B plus fluconazole 800 milligram daily for 2 weeks. Then after that, you move this patient then on the second phase, okay, where the patient will then receive fluconazole 400 milligram daily for 2 months. Then the third phase, fluconazole 200 milligram daily, that is the maintenance phase. Then you can continue fluconazole for a minimum of 1 year in total, and you can discontinue when the patient has, you have 2 consecutive CD4 counts of a value above 200 milligram taken at least 6 months apart. Taken at least 6 months apart, they constantly giving you a CD4 count above 200. You can then decide to discontinue fluconazole. So you can only start your antiretroviral therapy in this patient after 4 to 6 weeks of antifungal therapy. So you start antifungal therapy after 4 to 6 weeks, then you can introduce antiretroviral treatment. But cryptococcal meningitis in patients without HIV infection, you use the same induction regimen as in patients with HIV, except that the consolidation treatment, the treatment during the consolidation phase will be done with fluconazole that will vary from 3 to 6 months, depending on the clinical presentation and other underlying risk factors. And the maintenance phase does not play a significant role of here because of the patient normal CD4 count and a good immune system. So this is how you manage this patient. And of course, if your patient is found to have TB meningitis, you can then, of course, they will do the anti-TB drug resistance and to try to see resistance to rifampicin. If it's a susceptible TB, then you start this patient on first line anti-TB regimen. But if rifampicin is resistant, then you suspect multi-drug resistant tuberculosis. You can then start this patient on second line anti-TB drug regimen. So this is how you manage, you go about diagnosing and managing a patient who is suspected of having chronic meningitis. So thank you very much and goodbye.